person in a meeting of urologists and surgeons, but I try to do my best and act as if I am all good. Okay, so my topic, without much ado, my topic is role of radiotherapy in muscle-invasive bladder cancers. I'll be discussing this in two heads. First, we will try to, for a change, save the bladder, do bladder preservation using tri-modality therapy, sir. We will discuss about why are we thinking like this? Why do we want to do that in first place? Who are the patients who may benefit with this kind of a treatment, and then how we do it. The second broad topic that I'll be discussing is a patient who has underwent radical cystectomy and now has some high risk features. Can we do something to prevent the disease from coming back, to basically decrease the risk of locoregional recurrence in those patients? So the focus of our attention for the next 15 minutes will be a patient who has muscle invasion. About 30% of all the bladder cancer patients have this. I don't have to tell this esteemed audience that we are dealing with aggressive and potentially lethal disease here. Widespread, the standard of care, traditional standard of care has been radical cystectomy, but we do know that it is a major surgery with its own fair share of complications, even with improved surgical techniques and improved perioperative management. Tri-modality therapy is now developed as an alternative. And when I say now developed, what I mean is previous 3 decades. So the first reports date back to 3 decades ago, when the authors stressed that what we want here is a randomized controlled trial that will tell us for sure which one is better, which one is not. And to date, the zero out there shows that we have no prospective randomized evidence as of today. Because it's difficult to do a trial like that in a sensitive population like this, wherein you have to tell a patient that either you receive surgery or you don't receive surgery. Why do we want to do this? To offer the patient advantage of a good quality of life with a potentially reduced toxicity of surgery, but while giving the same cancer control outcomes as surgery. So one does not go without another. The outcomes have to be equivalent. The prospective evidence, as I said, the only attempted randomized prospective trial was closed early because of the difficulty in accruing the patients. In 2.5 years, they were able to accrue only about 45 patients, and there were major clinician as well as the patient preferences in accrual. So most of the patients, about 25%, 1/4 of the patients who were randomized to radical cystectomy arm in the SPARE trial that I'm speaking about actually received radiotherapy. So there's a huge clinician as well as patient's own bias in this. And so unlikely that we are going to have that answer in near term as far as prospective randomized evidence goes. But so what do we have? What we have is good quality systematic reviews, meta-analysis, and matched retrospective studies. This was a 2016 paper, big study, 8 studies were taken, 10,000 odd patients, no difference in overall survival, cancer-specific survival, and progression-free survival was seen. What was, however, seen was that the surgery patients, the patients who underwent surgery had a higher rate of early major complications. There was no difference in early minor complications in radiotherapy or surgery. Subsequently, in the last decade, 2015, 16, 17, major albeit retrospective studies have shown that the outcomes are similar. So, sir, the answer to your question is yes, radiotherapy is a potent alternative to surgery, but we don't have a prospective evidence. That is the long answer. The short answer is yes. So this was a major, the trial by Arkanjali here was a major systematic review. It was not a trial, sorry, it was a systematic review, about 14,000 patients, 31 prospective and randomized studies. The 5-year overall survival, if we see, it was 57% in patients who underwent tri-modality treatment and 52% in patients who underwent surgery. The hazard ratio for mortality was 1.22, and there was a 5% absolute benefit in the risk of dying in the patients who underwent preservation therapy. So what do the guidelines say? Do the guidelines concur with what I'm saying here, or do they differ? Do the guidelines concur? Yes. Do all the guidelines concur? No. So the NCCN and NICE guidelines have included bladder preservation as a part of management category 1 evidence along with the surgery. So stage 2, stage 3A, and in fact in patients even with stage 3B cancers, after NACT if we see, consolidation cystectomy and consolidation chemoradiotherapy receive the same level of evidence. However, ESMO, ISRO, EUA, all these societies have not yet endorsed chemoradiotherapy to the same level of evidence. The evidence for not endorsing is also not there. Time will tell us what happens. So there is long-term data available now. Recently, on 12th of May, 8 days back, this big study was published in Lancet Oncology. This was a propensity-matched retrospective study. So the next best thing after a systematic review or a meta-analysis, when we know that we're not going to have a randomized trial, is going to be a propensity score matched retrospective studies in which we take two groups of patients. For the students here, we take two groups of patients. We know that they have already received treatment with all the biases of clinicians and the patients. But when we still want to match as well as we can as a randomized prospective study, what we do is we match the risk factors in both the groups and then we analyze. So the propensity score matched analysis was done. 837 patients in radical cystectomy arm, 282 patients in preservation arm. And what we can see here is both. This is a Kaplan-Meier curve showing the outcomes, and we can see that both the curves are hugging each other. And in fact, the 5-year overall survival was very slightly higher in the TMT arm. It was 72% in the patients who underwent surgery and 77% for the patients who underwent radiotherapy. Now comes the risk of the disease coming back after radiotherapy. We have to counsel the patients. So we know that the salvage cystectomy rate in the historical series as well as in this study was 13%. So it ranges from 10 to 15%, and this study shows no difference. So why not spare the quality of life? Although the SPARE study was not completed, but it did show some difference in quality of life. At 1 year, radiotherapy scored over surgery in mean global health status and social functioning, although it was not a big difference. And the decline in body image and male sexual problems very specifically, which were there in the surgery arm, were slightly less evident with radiotherapy. So to conclude the question of why, I would like to say that both these treatments give us similar oncological outcomes, albeit this statement is not based on randomized prospective evidence, and it's not going to be based on that in the days coming ahead. What is most important here is a multidisciplinary shared decision making with the patient preference kept in mind. So my comment to Dr. Swarnam's point of taking a patient who is unfit for surgery and offering him an option of radiotherapy is, what about a KPS 80 patient who does not have many risk factors and who wants to retain his native bladder? What are we going to offer him? Are we going to say to him, no, you are fit for surgery, the best decision for you would be surgery, and trying to convince him in our clinic like that? He or she, based on his or her upbringing, might still give in. But it's our prerogative as clinicians to know for whom we can still offer preservation. So selecting patients now. This is the who has a T2 lesion, unifocal, no multifocality, no CIS, good bladder function, node negative. But what about a patient who has slight unilateral hydronephrosis, or just the CIS is just in vicinity of the tumor? What about that patient? Are we still going to sacrifice the bladder? Well, that is a myth. This is myth number 2 that showed good outcomes. Multifocality, some CIS, extensive CIS, I agree. We would think twice before offering. Large tumors, so large tumors, we can offer NACT and we can see response. We can bioselect for preservation. Locally advanced disease, the BC 2001 trial, it included locally advanced patients. Poor response to NAC, I'll come to that. and rare variant histology. All these are perceived contraindications but are not backed by evidence. They are backed by our own entrenched thoughts, perceptions. So selecting patients for TMT, let's choose wisely. It's no longer just restricted to unfit patients. All those factors that we have been assuming as contraindications are prognostic factors. They have not been shown to be predictive factors which can tell us which therapy will work, which treatment will not work. So, yes, regarding NACT, NACT is good. We should encourage our patients to receive NACT. A muscle invasive bladder cancer patient, T2, T3, N plus patient, NEC has shown from the trials, in fact VESPER trial also has shown that it improves outcomes. The ABC meta-analysis in 2005 showed that receiving NACT improves overall survival by 5% at 5 years. And so the residual tumor after NACT, let's not make our decisions based on that. That is a bifunctional product that also depends on the completeness of initial TURBT, that also depends on the response to NACT. So yes, it's a prognostic marker, but it is not a robust predictive marker to guide patient selection. So coming to the schema, how we do what we do, TURBT is the most important step. And here I would like to say, when we think of bladder preservation, the first thought that comes to all of us is that it is a non-invasive. So it's not a non-invasive alternative to radical cystectomy. It's a non-cystectomy approach. It's not a non-invasive, and urologists, as much as radiation oncologists, play a major role in every step of this treatment. And this treatment needs a multidisciplinary decision making as much as any other site of body. So after TURBT, we go to neoadjuvant chemotherapy. It improves overall survival at 5 years by 5%. It decreases the risk of mortality by 16%. Coming to radiotherapy, I will come to the details of radiotherapy later. Radiotherapy with radiosensitization agent has been shown to be better rather than RT alone. And then the most important aspect is follow-up and counseling of the patients. We have to tell the patients that you will have to be on a regular follow-up with quarterly cystoscopies for the first 2 years and 6 monthly thereafter. And in case, whenever we do detect either a muscle invasive recurrence or a non-muscle invasive recurrence, we will have to move forward and we should counsel the patients that a salvage cystectomy can be a possibility in about 10 to 20% of patients. At the end of 5 years, after the outcomes have shown that about 75% of the patients retain functional bladders. So that's a food for thought for all of us. Workflow basics. So when we use radiotherapy, continuous radiotherapy is better than split course radiotherapy. Back in the 90s and 2000s, from Massachusetts General Hospital, a regime was started of split course, giving some radiation, checking response. If the patient has responded, go ahead, complete it. If the patient has not responded, then those patients were shifted to the surgery arm. But later on, from studies from the Princess Margaret, Canada, it was shown that continuous RT, giving all of RT at one go, then giving the RT some time to act, then checking response, and then acting accordingly is probably better for the patients. NACT I have already discussed. Concurrent chemotherapy improves outcome. We'll see later the evidence about it. For cisplatin eligible patients that we'll further see in today's session, weekly cisplatin is preferred, or weekly gemcitabine also has shown equivalent results. RT dose and techniques I'll just discuss. Yes, so this was a trial, BC 2001 trial. It increased the chemotherapy, addition of 5-FU and mitomycin C increased the 2-year loco-regional relapse-free survival from 54 to 67%. Again, to stress, this trial included patients with incomplete TURBT, included patients with moderate hydronephrosis as well. Coming to the question of shorter radiotherapy course. So first of all, I'd like to tell that the radiotherapy course that we give usually comprises of fractionated treatments. Usually the dose is measured in SI unit of Gray, and we give 2 Gray per fraction. Bladder cancers, we started with 2 Gray per fractions of radiotherapy, and it usually was 64 Gray in 32 fractions. Later on, it was seen that prolonging treatment time after 5 weeks is probably accelerating the cell repopulation rate. we want to decrease the overall treatment time to less than 5 weeks. So then it was decided that the radiotherapy will be given in 20 fractions. So now the standard of care is 55 gray in 20 sittings given once daily. This new fractionation has shown a 29% lower risk of invasive locoregional recurrence, and it was non-inferior as far as survival and toxicity are concerned. Yes. So this 29%, there was a 29% relative benefit with hypofractionation as compared to conventional fractionation, and it was non-inferior for toxicity. This is the radiotherapy workflow. We simulate the patients. We do a CT scan. With simulation, we mean a CT scan with empty bladder, and we just contour all the bladder involved. We include any extra vesical extension. If the bladder neck is involved, then in males we also take about 1.5 cm of prostatic urethra, and in females we take 1 centimeter of urethra. And then we do radiation planning. The delivery of radiation in bladder carcinomas is not as straightforward as in some of the other sites. Bladder, as we know, is a dynamic organ. It fills, it moves differently every day. So what we have come up with, that we do a planning with empty bladder to improve reproducibility. Then we give it a population set margin, and we give it 3 margins. So those 3 layers we can see are small, medium and large. And every day before treatment, we take a CBCT scan, a cone beam CT scan on the treatment machine. We match the bladder for each of the volumes that we have drawn. In whichever volume the bladder is fitting the best, we choose that volume. The plan is already being made for all the 3 volumes. That is the plan library. We choose that plan and we deliver the plan on the couch on the same day. So this is termed as adaptive image guided radiotherapy plan of the day approach. So this is how we deliver the radiation. So for example, this bladder, we can see that it's fairly well accommodated in the PTV small. So then we choose PTV small for that particular day. Subsequent day it may have filled up, and we might have to choose PTV medium. Outcomes with this approach. This is a publication from my institute, and in about 106 patients, in which 30% received neoadjuvant chemotherapy, 80% received concurrent chemotherapy, and so these are the numbers. We use conventional fractionation, 67%. The late toxicity with treatment was seen to be fairly gratifying in the sense that it was less than 5%, either genitourinary or gastrointestinal. That was about intact bladder preservation. Now we have a patient who has already undergone radical cystectomy. Can we do something to improve outcomes in this set of patients? Why are we talking of adjuvant radiotherapy when there is no level 1 evidence? There is actually no level 1 evidence in urothelial carcinomas. It's only established in squamous cell carcinomas. The reason why we are for positive population, the overall survival at 5 years is about 10 to 40%. If they subsequently get a locoregional recurrence, the outcomes go down further. The median survival becomes 9 months only. And the problem is that locoregional failures are fairly underestimated when they happen, because we know bladder cancers metastasize early. They happen with distant mets. So locoregional failures are never addressed. So this trial showed that about 30 to 50% patients have locoregional failures, and if margins are positive after surgery, then that rate goes up to 68%. Has chemotherapy been able to help us with problems locoregionally? No. The answer is no. And why not when it is feasible? Because what will happen if the patient has a recurrence? We will have to give more dose with no bladder to push the bowel up, so that the patient will be saved of bowel toxicity. The dose in adjuvant setting is lesser. We can get away by giving just 50 gray without the bladder also. So the small bowel toxicity will be controlled. But the dose and salvage setting trial by Mohammad Zaghloul et al., which had 80% squamous cell carcinomas. The 5-year DFS with radiotherapy after surgery improved from 25% from surgery alone to 44% in patients who received radiotherapy. The only reason that this is established in squamous cell carcinomas is the outset was from this trial. But this could not achieve widespread and worldwide influence for urothelial, because in Egypt they do not have so many urothelial carcinomas. Subsequently, the trials have done and they have increased the percentage of urothelial carcinoma patients. So, coming to the question of who will benefit from this treatment, a risk stratification model, actually 2 or 3 risk stratification models have been made. This is the major one followed. It's from the University of Pennsylvania. So, depending on PT stage, margin status, and the lymph node yield in surgery, we divide the patients into low, intermediate, and high risk group. And the 5-year local regional failures, as we can see, keeps on doubling. So it goes from 8 to 20, keep more than double, and then 20 to 41%. So the 5-year risk of local regional failure jumps as soon as the margin gets positive or the lymph node yield goes down. Again, a publication from our institute, we saw that yes, the percentages were fairly similar. We had a 35% local regional risk and high risk group. The key takeaways from this study was we saw that the patterns of local regional failures was not as straightforward as assumed prior to the study. Many patients were failing out of the local regional pattern area. So there were 1/4 of patients who were failing in common iliac lymph node group. And the margin status is not the only factor on which we should base our decisions on. Of the 9 patients with a cystectomy bed recurrence, only 2 were margin positive. This has implication further in our radiotherapy volume contouring. Again, the guidelines have accepted adjuvant radiotherapy along with adjuvant chemotherapy and adjuvant nivolumab as standard options for patients with high risk features after surgery. Yes, so we know that the technique has evolved. The reason why we are able to discuss about adjuvant radiotherapy now is that the technique has evolved from 2D 4-field box fields to 3D CRTs and now to intensity modulated radiotherapy. The toxicities back in 80s and 90s were seen to be about 30 to 40% of grade 3 toxicities after radiotherapy, which is clearly unacceptable. It went down to about 7 to 8% with 3D CRT. And with IMRT, the current rates are said to be about 6%. This was a trial from Belgium, which took about 72 patients, primary endpoint of acute toxicity, and they found that acute grade 3 is still 6%. So we still have work on our hands. To improve outcomes, to decrease toxicities, first we have to be on the same page because this is a new treatment. So in 2016, this was a publication from, this is an international collaboration, multiple countries, multiple radiation oncologists. They sat down to decide what basically should be included in our volumes, because if our volumes of treatment are not standardized, the outcomes can't be. So based on the margin status, what was recommended was that patients who have a negative margin status, only the pelvic nodes will be treated. Patients who have a positive margin status, pelvic nodes as well as the cystectomy bed needs to be treated. And that's where this comes in. Only the margin status cannot be taken as the sole holy grail criteria to decide our radiotherapy volumes, because in our experience, in our patients in India, we saw that even with a margin negative status, many patients come up with a cystectomy bed recurrence, some soft tissue recurrence. And so we recommended that we should include the cystectomy bed regardless of the margin status. Similarly, other trials were also facing the same dilemma, and this is a 2022 update to the international consensus guidelines, which have recommended that the changes recommended to the existing contouring guidelines have been mentioned as to include the cystectomy bed in all the patients. Whenever we have to give adjuvant radiotherapy, cystectomy bed has to be treated. To include the proximal common iliac nodes, obturator borders need to be extended more medially, and presacral nodes need to be included till S3 lower border. This is an ongoing multi-centric randomized trial at TMC Mumbai. The sample size is 153 and we are about 15 patients short of completing accrual. A similar trial in US closed the NRG GU001 because of the problems of accrual. So we are looking forward to completing this trial early. The primary endpoint is 2-year loco-regional relapse-free survival. The protocol of this trial is just recently been published. So what we are doing is we are taking patients with locally advanced muscle-invasive bladder cancer following radical cystectomy and lymph node dissection with high-risk features only, more than PT3, PN plus, margin, any of these can be positive, or who received any CT, because if the patient has received any CT and is now YPT0 or YPN0, still we are including it because at the outset the patient was a high-risk candidate. We are randomizing into observation and adjuvant radiotherapy. And the volumes, as I discussed, we are taking all the cystectomy bed as well as the nodes, and we are treating it to 50.4 gray in 28 fractions. So, this is just a slide to document the, to show you the contouring volumes. This is how the cystectomy bed looks. Other ongoing randomized trials in this space are going on in France and Egypt. And as I told you, the American trial had to close early. So to summarize everything that I've spoken now, MIBC, tri-modality bladder preservation, is a therapeutic option and has clinical equipoise with the traditional gold standard of surgery. Long-term data is now available, guidelines endorse it, all guidelines do not yet endorse it. Organ preservation results in better quality of life and social function based on retrospective data. Salvage cystectomy may be required in about 10 to 15% of patients. Strict surveillance, strict counseling, proper communication, not just with the patient but with the full multidisciplinary team is required. Morbidity and mortality, which has been assumed to be more with salvage cystectomy, in good volume centers, the retrospective reports have not mentioned it to be greater than primary surgery. Radiosensitization is better than radiotherapy alone. Moderate hypofractionated radiotherapy, a shorter course, is not only non-inferior, but as far as local control is concerned, it is superior. There is benefit of NACT, independent of definitive modality, whether surgery or radiotherapy. And adjuvant radiotherapy is standard of care in squamous cell carcinoma, but presently has no level 1 evidence in urothelial carcinomas. Hopefully our trial will help us in that space. Thank you so much, all of you. Thank you to the organizing committee for having me here, and my acknowledgements to my